Our learning objectives for today are really to focus on and evaluate the impact of value-based care, particularly related to metabolic care. We know that this is a specialty that PCPs, when they're armed with the right information, and that's usually the latest research and expert guidance from an endocrinologist, can easily manage a patient's care throughout over time as their symptoms or treatment needs change. We also want to talk about how we're optimizing care delivery, because we recognize that whether you're in a rural market or a busy urban area, access to specialty care remains a challenge. Our patients wait significantly longer than they should have to initiate care with an endocrinologist or many different types of specialties. And my goal as the Chief Client Officer at AristaMD is to help your patients get that access and get value-based care so that when they need to see a specialist, they're armed and ready with the appropriate tests and information, and you can do that in-person referral when it's appropriate, and make sure that the specialist that they eventually see knows their complete medical history and the advice that you've received via e-consult or telehealth. On the clinical side, Dr. Oertel will focus on differentiation of multiple receptor mechanisms and how to enhance clinical safety and adherence. I will leave all the clinical stuff to Dr. Oertel. Just to give a little framing, and I know for those of you who've worked with us for a considerable amount of time, one of the challenges that many of you face is you refer a patient out and you don't necessarily get the complete treatment plan and history back from the specialist. That's one of the reasons you rely on us, and it really is why we feel confident in the specialists we work with, because we know they give excellent visit notes and e-consults, return to e-consults, with detailed treatment plans as well as patient education. So we want to eliminate that silo effect. There is a rising risk in this country. We're seeing higher incidence of chronic disease in endocrinology, and that, as well as the downstream impact of obesity, leads to hypertension and other complications. So we want to make sure that we are moving from that reactive care, my patient is now suddenly pre-diabetic, or my patient suddenly has hypertension, to reactive care, which is why we brought Dr. Oertel in today to help you spot the warning signs and manage that care and the risk for that patient for comorbidities going forward. And we recognize, particularly with an aging population, that the cost of waiting is high. When they have to wait to get treatment and we don't intervene quickly, their long-term outcomes, as well as the long-term cost to both the patient and our health system, increases. So there's not just an economic impact to your practice, to your patients, but also to our wider health system. So as I turn it over to Dr. Oertel, I just want to focus a little bit on the bottom right-hand corner here, the triple aim framework. We want better outcomes, rapidly reach A1C and weight targets, lower costs, reducing the cost of care, total cost of care, obviously a huge motivator for those of you that are managing at-risk patients, but also a huge motivator for those of you that are working with patients that have limited access or economic challenges, social determinants of health. We want to prevent them from disease escalation and the high cost that comes with that. And ideally, we want to provide our patients with an improved experience. We want to make accessing specialty care and engaging with their PCP a pleasant experience whenever possible. I know they're there for healthcare, but we also know that if they're happy in their PCP office and they continue their appointments regularly with the PCP, their overall life and wellness will improve over time, which is why we focus on keeping the PCP at the center of care. So with that, I'm going to turn it over to you, Dr. Oertel.
All right, well, thank you very much, and nice to be on this presentation to talk to all of you, and especially on a Friday at the end of the week. Thanks for coming on an afternoon. So we'll be talking about diabetes, something that we see every day in our office and your office as well. I first wanted to start off like, who do we screen? When primary care doctors ask me who to screen, I essentially say anybody you're actually seeing. This will be people who are asymptomatic above the age of 35. We should begin to screen. That should be people who are overweight, obese, if they have history of gestational diabetes, and a number of these risk factors, if you will: PCOS, metabolic syndrome, HIV, relatives with diabetes, treated hypertension, dyslipidemia, heart disease, and certainly medicines that can lead to hyperglycemia. Traditionally, these are steroids, but we can also see these with antipsychotics, and also HIV medicines, especially ones that include protease inhibitors. These tend to lead to metabolic issues, increasing the risk of diabetes. And these types of people included with this list should be screened annually. Here we go. And how do we diagnose diabetes? I'm sure many of you know this. It's just a quick review. A1C greater than 6.5 is diagnostic. 2, fasting glucose values. Fasting is 8 to 10 hours after food, so higher than 126. Or any random blood sugar. If you get a chemistry panel in the afternoon and it's over 200, that's likely pathognomonic for diabetes. Or if they do a 75 oral glucose tolerance test, if it's above 200, that's pathognomonic as well. And then if people do have symptoms and high blood sugars, frequent urination, thirst, unintentional weight loss, blurry vision, frequent infections, and like the photo over here shows, slow healing cuts or scrapes, then you have yourself a diabetes diagnosis. And a quick little graph on epidemiology. We know this, it is an increasing trend in America and even around the world, especially in Asian countries of recent, that diabetes is increasing. Here in America, the actual diagnostic amount of people with diabetes is probably at this stage about 30 million or more. Many of these people, unfortunately, due to reduced access to healthcare, go undiagnosed. And a huger portion, and this is what we're worried about as endocrinologists and physicians alike, is the amount of people who have pre-diabetes. 115 million, and this was from a couple years ago. So it's likely 130 million. I just couldn't find that information easily from research I was doing. But look at the graph; it's been going up really significantly since the year 2000. There's been thoughts on this. Internet decreased activity, just being more sedentary. But thankfully, recent data has shown some slowing of the trend and maybe even some plateauing or flattening of the curve in a few countries or a few states in America. So we're either doing something right. I think that's the nice thought with better medicines and better treatments. So hopefully we'll see what happens in the next 5 years where maybe we can eventually see a downward trend. But it's still quite high, way too many people with diabetes in America right now. Yep, and to go over the complications, this is something I pull out of my proverbial back pocket when I talk to patients in clinics. They may not have many symptoms, even though their A1Cs are above goal. We talk about the unfortunate complications. I generally say about a 2 times higher risk of people with diabetes having a heart attack or stroke. Unfortunately, eye disease is quite common with diabetes. It's the #1 cause of blindness, even in America. Kidney disease is kind of the silent disease of diabetes. That is still in America, the number one cause of hemodialysis needs is because of diabetes. Amputations. When you look at people with and without diabetes, there is a much higher risk of having non-traumatic amputations of toes and lower limbs. So we try to do a foot exam in our office and encourage foot care as they go home nightly. To look at their feet every night, make sure there's not sores, cuts or scrapes on their feet that we need to address sooner than later. What's really important from a financial standpoint is the cost of diabetes it's huge. I bet it's close to $500 billion come in 2026 when data comes out. So improving care, limiting complications, limiting costs will be very important for the financial side of healthcare. And then quickly going over some of the causes of diabetes. By far, type 2 diabetes is the most common type. I'd say maybe more of 90%. But when you look at the amount of people with diabetes, 10% could have a more potentially atypical cause. So with type 2 diabetes, as we know, there's variable amounts of insulin resistance as the cause, either from general metabolic issues, medications, lack of activity, foods, so on and so forth. Type 1 diabetes, which is destruction of the pancreas from an immune process, that is lack of insulin production. These people will need insulin for the rest of their life, unless treatments that are out there, which are being researched, come to market, if you will. And then the next most common we probably see is latent autoimmune diabetes of adulthood. That is essentially type 1 diabetes diagnosed at an older age. The usual cutoff is 40. They will have positive pancreatic antibodies. I usually get a C-peptide with these individuals, and there's varying amounts of insulin decline, either zero insulin essentially, or just reduced amount. The next most common, gestation will be probably another very much more common, but outside of that, MODY or monogenic diabetes. These are usually young people get caught with a chemistry panel that's abnormal, showing an elevated glucose. They're usually thin, where we would not suspect diabetes otherwise. They generally have a modest elevated A1C, negative workup for type 1, and they have a very strong history of diabetes in the family. This is generally from pancreatic function or insulin release issues, where they respond thankfully really well to generic medications like glipizide or glyburide. Gestational diabetes, I'll kind of move a little bit quicker. Cystic fibrosis has a cause of diabetes. Hemochromatosis, which is iron overload, it can essentially deposit in the liver, which can impact the glucose regulation, pancreatitis issues. And then ones we see very, very infrequently, Cushing's disease, which is cortisol excess, acromegaly, which is growth hormone excess, and then pheochromocytoma, which is adrenaline excess. All can lead to hyperglycemia with patients. And a question I often get when I work with these consults I receive from primary care is, what's the goal A1C? It really depends on the person, their age, their general health, and also, unfortunately, life expectancy. So for young people who are in college, let's say, I got a large university right behind me. When I see these individuals, I try to get their A1C to be 6.5, if we can do so safely and effectively. For the most common goal we have is for the general 30 to 60-year-old good health adult, 7.0 or less. And then essentially we make that less strict. As they get older, life expectancy, we make it even up to 8 or higher for some individuals. I jokingly say in office, this is the Oertel rule of diabetes, if you will. look at their age, divide by 10, and that's probably the A1C goal that you can go for. And then I'll switch over to talking about therapies. Still, the initial therapy that most guidelines will suggest is, or excuse me, I'll take a step back. When do we actually start treatment? It's interesting, if you will. 7.5 or higher, we would say, yes, this person will need treatment. You could offer to certain motivated individuals, if the A1C is between 6.5 and 7.5, intensive lifestyle modification. Try to get these people in with a dietitian, a diabetic educator, if it's possible, and follow up with them in 3 months to see if they have improved their control. But if they are above 7.5, we start lifestyle modifications along with treatment. And if it is moderately elevated, 2 treatments, quite elevated above 9, then they'll often need additional therapies. If it is somebody who has significant hyperglycemic symptoms, we do start insulin or recommend insulin above the A1C of 9. And sorry for this busy slide. This comes from the American Association of Clinical Endocrinologists. It's essentially what a lot of endocrinologists think of when we see people coming through our doors. As you can see, metformin is still the first-line treatment, followed by the GLP-1 agonists that are very popular out there. And then the SGLT2 inhibitor class is second line. We're trying to get away from using older agents because of the risk factors for hypoglycemia, weight gain, and also we're trying to take a more cardiometabolic approach and renal approach to diabetes. It's not just about the blood sugar, it's about what the blood sugar can do. So if we can leverage medications to get multiple endpoints covered, if you will, to help with heart health and kidney health, that will lower cost, improve patient outcomes, patient satisfaction as well, where we can reduce, utilizing other specialists. And people, of course, love the weight loss that is seen with GLP-1 and SGLT2. Again, I'll bypass this just for time reasons. Essentially, this is going to allow us to know how to titrate insulin when we're using that. I just tell people small changes and have appropriate follow-up. It's going to be like a 10 or 20% change with insulin to get them to a fasting glucose goal of, I would say, 110 to 130 roughly in my office at least. And again, yep, this just describes the potential benefits and risks of a lot of the diabetic medications that are out there. So sorry about the complex slide, but it's just really to show all the medications, all the potential risks and benefits, and what we should all think of and kind of steer our patients to. On the left is better. As we go to the right, it can be a little bit more challenging. All right, metformin. In my training, we had somebody who was doing lots of research with metformin. So that got kind of ingrained in me that it's a great medication. For patients who like to take a more natural approach, this is what I pull out again is it's a derivative of the French lilac, interestingly enough. It is a cheap medicine. It's been around for 50 years. It's been proven safe, no matter what the internet or social media may say. And there's even other health benefits that can come from metformin that I'll discuss next. It does a great job at lowering A1C and fasting blood sugars with the percentages that we list here. It can also help with the dyslipidemia with its effect primarily on the liver. And it can even have some cardiovascular effects from a study in the 1990s when we didn't really have many medicines to choose from. And other things too, with higher risk of colon cancer, unfortunately occurring in America. We'll talk about in a few slides how this can reduce chances of various cancers, including colon cancer. All right, so here we go. So metformin does a great job. It was associated back in the 90s with lowering by 32% complications from diabetes. When we begin to see the kind of the lines vary from the baseline treatments within 5 years here, we think that's actually quite good. We're going to see with newer data, with newer medicines, that we can see a divergence from usual treatments and the intervention group within weeks, or not weeks, but months to just a few years coming up. Yep, and same thing with targeting people, overweight people with type 2 diabetes. There is a 42% reduction compared to conventional therapies in the 1990s, which are, the sulfonylureas and insulin back then. So that's why we just love metformin, and I'll move ahead. So with this, it's going to talk about cancer incidence. We have known for a little while, especially if you look at the top right-hand side under colorectal cancer, there is a nice reduction in incidence of colon cancer with patients treated with metformin. We also see it with hepatocellular carcinoma of the liver, and then less so with lung cancer. And then moving right along to the newer agents, the GLP-1 agonists. There have been some on the market for years, 15 years. Older ones have come and gone. Bydureon used to be on the market. Tanzium used to be on the market. But now we're typically using the weekly agents, Ozempic and Mounjaro. I've been putting some people on Victoza because it has went biosimilar or generic. But they're great medicines. They do multiple good on the body. The first thing it does is it stimulates glucose-dependent insulin release from the pancreas as blood sugars increase. We really see the postprandial blood sugars get positively impacted by these medications. We also see the food hit the small bowel later, and the small bowel is what absorbs sugar and nutrients. So the spikes that we've seen on CGM monitors, we just know that being more blunt. We see that being more blunted with these medications, and it does reduce appetite at the level of brain and increase satiety at the stomach. We know that weight loss can occur with these medications. Other things that we may not think about much with these medications is that it can also really reduce glucagon. Glucagon is the anti-insulin hormone that raises blood sugar. So it can actually reduce that hormone to further improve diabetes control. Weight loss is seen. I've had some people, gosh, maybe you guys have seen it too, but up to 25% is the weight loss I've seen. But the research has shown around 15%, maybe a little bit more with the Mounjaro versus the Ozempic medications. But all in all, very good medication. Cautions, though, I have with patients. I try not to give it to patients with known history of pancreatitis or medullary thyroid cancer or multiple endocrine neoplasia type 2. Thankfully, medullary cancer, I've only seen 2 to 3 people in my career with that disease. And then we use caution with pancreatitis. If it's a very mild form, I may use low doses. If it's a severe case, then I try to avoid these medicines. Yep, and it's a great cardiovascular medication, as I was talking about. We see divergence from placebo with the medications, gosh, as little as 16 months. So there's much, much lower risk of having heart disease or non-fatal stroke if we use these medications. I'll wait for a little bit while my slide pulls up here. Here we go. And even more recent data, we've had the heart data for, seems like approximately 5 years. So maybe in the last 1 to 2, maybe in the last 1 year, we have known that Ozempic can also reduce the kidney disease. aspect of diabetes. So 24% risk of slowing GFR decline with these studies, or with this medication. I think the mechanism is still trying to be worked out. We're potentially just saying it's better blood sugar control and weight loss that's leading to these improved kidney benefits. Also, yeah, we don't really see this with many studies. We usually try to study for as long as possible. This flow trial was actually ended quicker because they saw that divergence from placebo so quick and really nice right here. So they didn't want to, I guess, prolong the study to be 5 years, which is what I think they were planning to do. All right, next class. These are sodium glucose cotransport inhibitors. The brand names for the majority of these medications are Invokana, Farxiga, Jardiance. It's a good medicine if people want to avoid weekly injections. Mechanism is it's essentially they block a receptor in the kidney where the reabsorption of sugar is blunted. So most is diverted to the urine. This is approximately 100 to 200 calories worth of glucose being shunted through the kidney out to the urine. The benefits are blood sugar. It's a little bit less robust than the GLP-1 agonist. People can still lose weight because they're putting 200 calories worth of energy through to the urinary system, so they can lose 5 to 7 pounds. It is essentially a glucose diuretic, so the blood pressure can get improved. Cautions with this one is, as far as diabetes goes, we don't use them for blood sugar lowering when the kidney function is typically less than 25. They can be used with other indications, heart disease, and if we're trying to use it strictly for nephro or kidney protection, we can use those at a lower GFR. What I try to tell people to do with this medication is, as it increases urine production, we need to increase our water intake, drinking 1 extra glass of water per day to combat that water loss. And I try to check a basic metabolic panel 1 month after starting these medications. It's normal to see a slight bump in creatinine. We just don't want to have significant changes seen. I also try to talk about the GU hygiene necessary for these medications, especially for females. Females will have a 10 to 15% risk of developing a genital yeast infection. And then finally, there's this term called euglycemic diabetic ketoacidosis. It happens quite infrequently, but I just wanted to mention it. It's where people will have normal blood sugars, but they present to the ER with acidosis. We think it's from these medications lowering blood sugar, which then in turn lowers our insulin production, and that sets off a pathway of ketogenesis, essentially. This is typically seen if people develop infections, pneumonia, skin infection, otherwise higher stress can lead to this condition. But yeah, they're great for heart disease, which is wonderful because thinking back, patients with diabetes are at 2 times higher risk of having heart disease. So with this very large study, again, it was a short study because I think they may have even reduced the time length with this duration. We see nice divergence from general care to the use of empagliflozin with this study. So lower chance of heart attack and stroke is seen with these medications. With this, the etiology we think is due to lower blood pressure, offsetting some pressure from the heart, from the pumping mechanism, and from glucose lowering and weight lowering as well. All right, and then basal insulins, I'm sure you guys all know this. The newest ones that are out there are Toujeo and Tresiba. There was going to be a weekly insulin coming out. I think it's kind of going back to the drawing board from studies that came out with it. I was really looking to see that one come out. But I try to recommend to my patients and with consults the use of Toujeo and Tresiba, or just insulin glargine U300 and Degludec U100 or U200. Those are becoming biosimilar as well, because there's lower risk of hypoglycemia with these medications, which is quite important for all of our patients, because that can be quite dangerous. And then moving forward to some of the technologies we have. Continuous glucose monitors are amazing, amazing things. There are a couple different companies I'll talk about next. These measure not blood sugar, but interstitial glucose. There are cells, or there's fluid between all of our cells that have many different nutrients in addition to glucose. Essentially, what happens with these devices, there's an enzyme at the end of the filament that the blood sugar activates an electrical signal. The higher the glucose, the higher the signal, and that's how the blood sugar gets shown on the phone or the device. To be noted with these devices, there is a lag time between the actual blood glucose and the interstitial glucose. So I tell my patients in clinic is, if you feel like you're having a low blood sugar, but your sensor is normal, you just need to do a finger stick glucose, because you could actually be low. And if you don't do anything about it, it could get worse. 50 to 30 minutes is sometimes some of the lag. So if you're low now, you could be even more severely low if you don't kind of do anything about it and just rely on the blood sugar from the CGM. So here are the main ones that we have available in America. The one on top is Dexcom G7. It's a 10 to 15 day sensor. 15-day sensor came out a few months ago. And the one on the bottom is a FreeStyle Libre 3 Plus. These are sensors about the size of a nickel or a quarter. They're either placed on the back of the arm or the abdomen, and they measure blood sugars to these devices, giving graphs and trends that patients can use to have them modify their lifestyle. I think that's what I see a lot of my patients do. They can see a usual breakfast that they may have spiking their blood sugars to 250, which is often a cereal. And then maybe the next day they'll say, let's just try to have a piece of peanut butter toast. Oh man, my blood sugar only increased to 150 with that meal. Let me just try to get away from cereal, if you will. So I think that's what patients really like with these. Other ones that are out there that I've used some is a implantable CGM called Eversense. It's a 1-year sensor. And if patients have a specific pump, there's CGMs available for that one. I think they should be used more in America, and I think they could be. Anybody with type 1 or type 2 diabetes that's treated with insulin, I feel like they should have a CGM, because it will help reduce complications, improve adherence to medication and diet, and reduce their chance of having hypoglycemia that could be severe, debilitating. In our office and in a lot of offices, these are fairly easy to download. Just a little bit of training to staff to grab these reports. This is what a typical CGM report can look like, showing average glucose, this thing called GMI, which is an estimated A1C, and then something called time in range, which I will go into next in a few slides, I believe. But essentially, it just shows you during the time on the far left and right is midnight, middle part of the day is noontime, and so on and so forth. So they can see trends with this great report. But A1C, it does have limitations. The hemoglobin A1C can really just tell us what the average blood sugar is. And hemoglobin A1C can have inaccuracies. If the patient's anemic, if they have sickle cell anemia, thalassemia, lymphoma, any disease of the blood, that can make the A1C falsely low. Or if they just donated blood or have a GI bleed, anything that can affect hemoglobin can affect the A1C. And as we see here, I love to point this out, is all of these graphs on the right side depict an A1C of 7. However, the one on the left, as you can see, they're having high and low blood sugars quite often. That person on the left will actually have a much higher risk of having complications than the one on the far right. We're thinking every time spent in A1C can lower by a few percentage points the complication risk. So we really like to see the graph on the far right with majority of the time spent in range. And then to break it down even more, there's been a consensus, worldwide consensus. What is the goal for percent time in range? That is 70%. We think if people can get to 70% of their life being between 70 and 180, their A1C will be 7. And again, that will significantly reduce complications from diabetes. That essentially equals 17 hours per day. Other goals we try to have is to reduce the risk of hypoglycemia. I would really say that the consensus is 4% or less would be ideal. 5% very high, and very high means higher than 250 would be other goals that we would have to keep the person in a healthy range. So yeah, 15 minutes. I'll just point this out real quick. 1%, how much does that equal in a day? That's 15 minutes. So if a person's having a low blood sugar, this is where I'm coming from. If it's a low blood sugar lasting 15 minutes, that's a pretty typical duration. So 4% would be an hour of hypoglycemia. That's where I try to personally keep the low risk even lower than the 4%. Insulin pump therapy. I think these are also great for many patients if they are type 1. I try to get most of my patients on one of these pumps. Back a few years ago, we really only had 3 pumps, the Medtronic, Omnipod, and Tandem. iLet is a pump, at least in the Midwest where I work, hasn't been greatly available until maybe the last 1 to 2 years. Twist in the Midwest came out to us just a few months ago. All of these are great. All of these pumps have moved to something called a hybrid closed loop system. As we see with this graph, it takes a continuous glucose monitor talking to a insulin pump or even a app on a phone that uses an algorithm. All these have different algorithms where it is consistently modifying the insulin delivery to regulate blood sugars. And this is happening while the person is sleeping, on the presentation and not thinking about their diabetes, before eating, after eating, to keep blood sugars in range. Some of the systems will even give automatic correction boluses to regulate insulin. They can reduce insulin delivery, stop insulin delivery to prevent hypoglycemia. So I do get a lot of pushback in clinic. They don't want to be hooked up to all of this stuff on their abdomen. But after they get on it, they do, majority of the time, have a much improved quality of life, less fear of hyperglycemia and hypoglycemia. Go next. Yeah, but this is just going back to things we may not always think about because diabetes is multifaceted. There's so much to cover for if you just see people for diabetes. That's where I really feel for a primary care physician. You have to talk about depression. You have to talk about blood pressure. You have to talk about, oh my gosh, so many things. But if we could at least once a year at least talk about other things that are important. Try to talk about diet, even a 60-second review or discussion about 1 or 2 simple changes they can make would go a long way. Same with activity. If they like to walk, they try to push them to do it maybe 1 extra time per week or go for a extra 5-minute duration when they go. I do think statins are quite beneficial. So anybody above the age of 40 at least, I'm trying to put on a statin, even if it's one that is a very low dose of like atorvastatin or rosuvastatin. That can reduce their risks quite a bit. People with diabetes, I do try to get essentially to a high-intensity statin, atorvastatin and rosuvastatin. Blood pressure, goals 130/80 for most studies. ACE and ARBs are what we generally would suggest. Calcium channel blockers are usually second line as we begin to look at treatment recommendations, especially if there's protein. But also the SGLT2 inhibitor class often is what I'm using next if blood pressure is actually not at goal and they're on maximum dose of ACE or ARB. And then GLP-1. Let's say they do diet and exercise for 3 to 6 months, and they just wanted a little extra help. These shouldn't be, criminalized or shamed like they're doing something wrong to get on these medications. It's really just trying to help them get to the best health that they could possibly do. And then I guess another thing, smoking. It greatly increases risk of many, many complications on the heart, eyes, and kidneys. So trying to get them to stop smoking would be something that's not always thought of to help improve their diabetes. And also nicotine, it actually enhances insulin resistance. I've had many people simply stop smoking and their A1C comes down by 0.5 point just from limiting the insulin resistance aspect of nicotine. So with that, I think I may be coming to my last slide, so I will turn it over to everybody else on this presentation. So thank you.
Thank you, Dr. Oertel. I want to wrap up with where we started, that our real goal here is to not wait until the patient starts to fail or has complications or starts to see, as Dr. Oertel mentioned, he's putting patients on a low-level statin. He's trying to prevent the heart disease, the stroke, the kidney disease, and even lower cancer risk by getting that insulin under control and manage it. So we're here, AristaMD, and the doctors like Dr. Oertel that support us are here to help you be proactive in managing patient care and improving not only their outcomes, their quality of life, the length of their life, as well as lowering the cost for both you and your patients. As many of you know, and I know we've had multiple webinars on this, our primary delivery model for expert specialist advice to this point has been e-consults. In the last 2 years, we have launched longitudinal care, which typically includes both e-consults and telehealth. The one thing that's missing from this slide that I think it's important to mention is we wrap around our telehealth services with care coordination because we recognize, particularly with patient populations that are either struggling with social determinants of health or are elderly and less comfortable with technology, our care coordinators reach out by phone, make sure they're all ready and to go and able to use our telehealth services. They also support them when they need additional testing, imaging, lab work, to make sure they're able to find and schedule easily for that care. And then finally, we are supporting in-person care in a number of specialties, either by routing within the network, your preferred network, or in some cases where access is constrained, we are actually bringing in our own specialists to either perform care for those patients, evaluate patients for things like fragility is a great example, or in cardiology to come into markets with limited resources to do echoes so that we can get your patients the access to the care that they need and the diagnosis they need to get an appropriate treatment plan in place. And endocrinology is an area where we are definitely supporting that with telehealth services, again, particularly in those areas where access to an endocrinologist is challenging for the patient. I do have a sample e-consult here of Dr. Oertel's, and after this, we will share it. It's for your review. I am not clinical. I don't speak to the clinical, but I think this was an excellent example of where he provided a, a thorough evaluation of the patient's medical record and detailed, not incredibly extensive, because that's often not what you need in the form of an e-consult, but precise and directive that allows you to treat your patient and manage that patient in the primary care setting. This is exactly the type of guidance we want to see from our specialists. And so again, I want to thank Dr. Oertel. And this is exactly the type of care that can be delivered via e-consult. And I just harken back to that prior slide. When it needs to go beyond this, we want to help support you in that as well with telehealth or in-person routing or care coordination or whatever you need to meet the needs of your patient. And then this is sort of the overview, and I got a little ahead of myself. We're trying to solve problems. You know, I'm very mission driven. I'm based in Atlanta now, but I grew up in West Virginia, where the geographic barriers, transportation challenges, ability to schedule, because you would have to drive 90 minutes or more to the Baltimore or Washington, D.C. area to see a specialist, often constrains patients. You know, fortunately, being in Atlanta, I don't have those challenges anymore, but I still see access to care challenges. And when I visit many of the clinics that we work with across the country, there are a multitude of reasons why patients are unable. They lack the ability to drive themselves. They need a caregiver to come support them. Again, distance, time off work. So the work that you as primary care providers are doing makes a tremendous impact. And we want to support that care by continuing to eliminate the unnecessary visits, increase the access to specialty guidance via e-consult, via telehealth, via assistance to care programs in the community, which is one thing that we're doing now, particularly in the Midwest. Deploying those evidence-based care plans like Dr. Oertel spoke to today, manage those chronic conditions, and finally provide the follow-up care and monitoring support that you need. Let me just see what else we've got here. So just a quick summary: network routing, we do that today. Direct contracting and on-site care are additional services we offer when your patients or your practice has that need. So if you have any questions about that, please don't hesitate to reach out. My email address is very easy. It's kcali@aristamd.com.